This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Hello, I'm Dr. Sujana Chandrasekhar. I'm an ear, nose, and throat surgeon in New York City and in Wayne, New Jersey. My co-host, Marina Kurian, who is a minimally invasive surgeon in New York City, is not able to be with us today, which is really unfortunate for me because I love our chit-chats and I love our repartee, but she will be back when we go live again in 2 weeks. We have an amazing show lined up for you today. Normally, Marina and I just talk about COVID for the first few minutes and then talk about some other healthcare subject. But today, we're actually going to talk about COVID vaccines, about COVID boosters in children, COVID in children and in adults. And then we're going to talk about spirituality in healthcare. And I think after this very long, cold winter of COVID that has lasted almost a year and 3/4 at this point, it's time for us to talk about the mind, body, and soul as one. We have wonderful guests. Dr. Natasha Burgert is a pediatrician in Overland Park, Kansas, who is also a writer and a spokesperson for the American Academy of Pediatrics. And Dr. Kristin Collier is assistant professor in the Department of Medicine at the University of Michigan Medical School and the founder and director of Michigan's program on health, spirituality, and religion. We will be talking not just about the impact of COVID on people, but the impact of the pandemic on people. We are really fortunate to meet such amazing physicians today. So please share and like and tag your friends who might be interested in watching. We are live on Facebook, on YouTube, and on Twitter, and on Shree's LinkedIn. We are carried on WBAI 99.5 FM in the New York area and WBAI.org on Mondays from 2 to 3 p.m. Eastern Time. And we have a podcast. We're so fortunate that we carry our shows now as a podcast on Apple Podcasts and on Spotify. So if you enjoy podcasts or if you just can't get enough of our voices while you exercise or commute, please do check us out there. And if you can leave a favorable review, we would really appreciate it. So there has been a lot of news regarding COVID-19 this week. And unfortunately, the news, it's sort of like watching a tennis match. It's a bit confusing. So we're going to talk a bit about how to get whatever the reality is through all of the changes in the news cycle this week. Unfortunately, in the United States, we keep passing awful milestones. We have over 683,000 people who have died as a direct result of coronavirus infection in the United States. And that is 1 in 500 Americans, with nearly 43 million cases of COVID. And what happened was we had, a couple of smaller waves and then a huge wave of cases and deaths earlier. And then the vaccines became available. And we all looked forward to this sort of like summer of joy, where, everybody would be vaccinated and the virus would start to become a thing of the past. But unfortunately, everybody is not vaccinated and the virus is not a thing of the past. And the Delta variant and the other variants that seem to be coming up in the future are actually more easily contagious and more aggressive than the initial type of coronavirus. So you can see on these graphs, this second wave of cases and then deaths kind of shadow that is pretty high across the United States. We certainly have areas in the United States that are better vaccinated than others, but only about 50% or a little bit over 50% of our country is fully vaccinated. The rest of the world is not better, as we know. The UN General Assembly was in New York City this week, and the Secretary General Guterres declared that we're on the edge of an abyss with COVID, with climate change, etc. There have been 231 million cases and 4.7 million deaths worldwide from COVID, with 511,000 new cases per day and over 9,500 new cases per day around the world. Like, these are horrible statistics, and these are particularly awful when we realize that the COVID vaccines were developed and were approved in the United States and England and across the world in December of 2020. As I said, just over about 50% of the US is fully vaccinated. 44% of the world has received at least one dose, but only 2.2% of people in low-income countries have gotten at least one dose. And the reason that that matters is not just because there was an amazing Global Citizens Concert to raise awareness and funding for that, but because we do live in a global society, and we live in a world where viruses, like people, easily travel around. So it's really, really important that we brainstorm ways of getting vaccines to people all over the world, because vaccines do work. And once we welcome our guests, I'm going to talk about that a little bit more with them. Finally, before we welcome our guests, I want to tell you guys that September is officially Women in Medicine Month. And we send the warmest of wishes to all of the women in medicine who have been guests on our show and who watch and listen to us. And a shout out to our She's on Call friend and guest, Dr. Mark Shapiro, who was honored by the Women in Medicine Summit this week with this year's He for She Award. So congratulations, Mark, and happy Women in Medicine Month to all of us. We are live on YouTube, on Facebook, on Twitter, on Sri Srinivasan's LinkedIn. Thank you, Scroll.in, for carrying us. Thank you, WBAI.org, for carrying us live, carrying us on Mondays from 2 to 3 p.m. Eastern. And as I said, we have this podcast, so please check us out on your Apple Podcasts or your Spotify podcasts and let us know what you think. But only let us know if you really like us. No, you can let us know either way. Let's meet our guests. Dr. Natasha Burgert is a pediatrician in Overland Park, Kansas, who is also a writer and a spokesperson for the American Academy of Pediatrics. And we're very excited to talk with her about COVID and vaccines in children, as well as quality of life. And Dr. Kristin Collier is assistant professor in the Department of Medicine at the University of Michigan Medical School, Go Blue, and the founder and director of Michigan's program on health, spirituality, and religion. And it's interesting because Dr. Burgert takes care of the youngest, and Dr. Collier takes care of all adults, but really cares for the elderly a great deal. And these are two groups that are really important to care about and talk about. And so welcome, Dr. Burgert and Dr. Collier.
Thanks for having me.
Yeah, welcome. Thanks.
I'm really happy to meet both of you. I know, Dr. Burgert, you were on Marina's show on Sirius XM this week, and really it's a joy to talk to you almost in person like this.
Nice to be here. Thanks.
So, let's start by talking about vaccines. And I gave some statistics about vaccination rates in the world and vaccination rates in the United States. And you can see clearly that in places where vaccinations have occurred, people are getting less COVID and less hospitalizations. So there's a graphic here that shows sort of in green the areas where there are high, sort of the schematic is green means high vaccination, low hospitalization, and sort of that purple means low vaccination and high hospitalization rate. And if we look at the map of America, and this was published in the Washington Post a couple of days ago, you can see that sort of the Northeast and the upper Midwest have done really well in terms of high vaccination, low hospitalizations. But in fact, the South and Southeast and parts of the Northwest are actually not doing very well. And then I noticed that there's actually no data from Kansas. So Natasha, maybe you can tell us what's happening on the ground where you are.
I think it's been an interesting few weeks. I'll say that we've been very busy here in the Midwest, and what's interesting about all of that data is it's determined by the state. So Nebraska doesn't report either, so it's just speculative, which puts us in an interesting position when we're trying to make clinical choices. I think that we're seeing both in our offices the reflection of those vaccine rates in our communities where they are fairly high. I'm in the Kansas City area, so we are higher than the state of Kansas proper, and our vaccination rates are quite high. Our hospitalization rates have been decreasing in both children hospitalizations and adult hospitalizations in the last 2 weeks. We're very thankful for that. We're also in our metro area, we have started school. The vast majority of our school districts are universally masking our kids. I think that's helping with control of spread until these littles can get vaccinated. And we're also starting to see academic data in different parts of the country that are patterning that vaccination and hospital rates. So in the South, for example, they are having higher rates in their schools, and in the Northeast, it's lower.
So it's interesting because I think there has been so much politicization, as we all know, about the COVID pandemic, about whether or not to mask, whether or not to distance, whether or not to vaccinate, and the use of sort of random medications that are really not helpful in this disease and may in fact be hurtful. We had a lot of news, as I said earlier this week. So what happened on Monday was that Pfizer-BioNTech reported their data from the children's study from vaccinations in 5 to 12-year-olds, which I have to say a lot of those subjects in that study were skewed to doctors' kids. A lot of my friends were like, yes, where can I sign my kid up for the 5 to 12-year-old vaccine trial? So that report looks very promising. It looks like there may be a way for emergency use authorization by the time, hopefully, Halloween rolls around, which would be incredible. On Thursday, the FDA said, oh, we should give boosters to people who are over 65, people who have underlying medical conditions, and people who are on the front lines. That includes healthcare workers, teachers, and grocery workers. And then on Friday, the CDC initially said, okay, we will approve it for over 65 and underlying health conditions, but not for frontline workers. And then Rochelle Walensky, who is the head of the CDC, Dr. Walensky, said, wait a minute, that vote was really tight, and she sort of exerted her parliamentary privilege, and the CDC is now going along with the FDA. So clear as mud, right, Dr. Collier? What do we make of this, and how do we counsel our patients?
So I do think the baseline message is clear. Vaccines help protect you against COVID-19. We know the data shows that if you are unvaccinated, you are 17 times more likely to end up in the hospital.
Say that again.
17 times.
That's impressive.
Big factor, right? To be hospitalized versus someone who's gotten vaccinated against the virus. We know that certain populations are more affected than others. Like at the beginning, you showed that devastating graph that showed the numbers of people who have died in this country as a result of this virus. That big number of 683,000 people, it's overwhelming, honestly, to even think about, really, of all those lives. And when that number, I think, really hides to some more devastating data that we have. We know that disparities exist in this virus and how it affects certain populations. We know that Black and Indigenous people of color have been more disproportionately affected by COVID-19. We know that the elderly have. We know pregnant women are 22 times more likely to die if they have COVID than their non-pregnant comparators. And so this virus doesn't care about our politics. It takes whoever it wants. And it's very unpredictable. I think, in as adult doctor, I've been practicing medicine for 20 some years. We've never seen really a virus like this, right? That's so unpredictable and can wreak such havoc in every single organ system. We think of COVID primarily as a respiratory virus, but honestly, a lot of us think of it as a whole body virus affecting the heme system, the neurologic system, the cardiac system, right? The immunologic system. It's devastating. So the underlying message is get vaccinated, it protects you. And then we are so thrilled as a medical community now to have this clear message from the data that if you have been vaccinated with Pfizer and you are 6 months out from your second vaccine and you fit into one of the groups that's recommended for booster, please get your booster.
Thank you. I appreciate that. We have people watching from all over. Shri Srinivasan is watching from New York. Robin Kogan, who is the relentless school nurse, was a guest on our show, is watching from right outside of Philly in South Jersey. Jenny Gormley is watching from Chagrin Falls. Oh, I love the name of your place, in Ohio. Lakshmi Ramanathan is watching from Houston. Linda Lawrence is watching from Long Island. Vijay Sundaram is watching from Ottawa, Canada. Nancy Ross is watching from the Upper West Side in New York. And Ellen Austin is watching from New York City. Thank you all for watching. Natasha, we've talked previously on the show about that Swiss cheese model for COVID safety precaution, right? The concept of one size does not fit all for any infectious disease, but certainly we've become very cognizant of it. As Kristin said, this is a very unusual virus, very unusual. We can't predict the severity. We can't predict why one family member gets really sick and the other person gets almost no symptoms at all. So when we talk about it, we talk about, distancing and washing your hands and wearing a mask and HEPA filters. And then you can see that last one on the left nearest to that person is almost a solid piece of cheese with just a tiny hole in it. And that's the vaccine. So we have, as you said, children are all going back to school, and thank heavens in your area, it's mask mandates. New York City had mandated vaccines for all of the adults working in the school system, and that was actually halted, which is, in my mind, very unfortunate and is being looked into by a 3-judge panel now. But tell us about vaccines for the adults and the children in schools and what we should be looking at.
Throughout this whole pandemic, we were spreading the virus to kids through infected adults. It was infected big people that is giving it to our littles. And so by protecting our bigs, we protect the littles. In getting as many adults vaccinated drops community rates, and that keeps the virus out of people's homes, and that keeps the virus out of people's schools, and that protects the kids. So that big piece of cheese on that Swiss model, or the Swiss cheese model, is so important for adults because the ripple effect of vaccinating an adult does trickle down to our kids all the way down to infancy. And just like was mentioned earlier, getting like a pregnant person vaccinated, that vaccinated adult helps that vaccinated infant. It's passing immunity to that infant as well. So there's a lot of different layers to the Swiss cheese, but I think that most importantly is we have one that is free and most effective and is going to help everyone in our community to be able to get vaccinated as soon as they're eligible. It will protect the people who are not eligible to be vaccinated.
So, I think this is...
That, if you don't mind, I just wanted to comment.
Sure, absolutely, Kristin.
So just the beauty, I think, of we're all connected, right, in a beautiful way. But especially thinking about how our actions affect others here in this pandemic, I think is really important to think about. I think Natasha brought that up really well with thinking about how the ripple effect is seen. So, and speaking specifically about pregnant people, I just wanted to bring up, there was a recent study that I saw that was published out of NYU Grossman School of Medicine, and they looked at pregnant people who had been vaccinated against COVID-19. And they looked at 36 infants born to moms who got either Moderna or Pfizer, a vaccine, and then where they were pregnant. And they looked at their umbilical cord blood. And all 36 infants, they found protective neutralizing antibodies against the virus. And so their babies will have immunity. And so it's not just like you vaccinate yourself and you're protected, which is great and wonderful, but these ripple effects, right, that we have talked about a little bit already today, so important to be cognizant of as well.
I think that's a terrific point. I think, the American College of Obstetrics and Gynecology came out very strong advocating for vaccines in pregnant people. But, the adoption of these sort of scientific guidance is not as much as we would like to see by the public, and sometimes not even by the physicians. And I think, physicians heal thyself. Like, we need to really remember that, yes, we are in a caring profession, we are in a nurturing profession, but we are in a scientific profession. And I think, relying on the data is really important. Robin Cogan, who is a school nurse and head of the school nurse group in South Jersey in Camden, wants to share what's going on in her community. And she says the third week into school with students, she's in an urban district with a lower vaccination rate, less than 53%. So as you said, Natasha, all of Kansas is not Kansas City, right? All of New Jersey and New York is not Camden. And so what they're seeing is that they're seeing 400 kids that had to be sent home for quarantine from either close contact or COVID-compatible symptoms or confirmed COVID. And then they're seeing kids who are coming to school waiting for COVID results or coming to school already symptomatic. So, Dr. Burgert, what do we tell these parents? Like, how do we help them do the right thing for their children and for their child's school community?
This is a big problem with testing access, because when people are trying to do the right thing and coming in to get tested, it almost feels like they're getting punished, right? They're doing the right thing to get tested, but then if they don't get their test results back for 2 or 3 days, then they're out of work. The kids are out of school. Not everybody has remote learning for every community. So it's really discouraging people from getting their children testing, which is a big problem. We have to keep testing our kids in order to keep the virus out of the school. That is going to continue to be important even when the kids start to get vaccinated, because we know that not all kids are going to get vaccinated immediately, and not all kids are going to get immediate protection after that first dose. It is going to take time. And so throughout this whole holiday season that's coming up, testing is going to be a vital part of that Swiss cheese model to be able to keep our communities and our schools open and the kids in the classroom.
And I think Robin points out that pooled testing is being done in some schools, but the participation rate is low. We talked about pool testing ages ago, it seems like, on this show. First of all, it seems like the pandemic's been going on for like a decade. So, I feel like I talked about this when I was a much younger woman. And that's a great way to test, right? Everybody spits into a cup, and you have 10 kids who spit into a cup, and if the cup is negative, all 10 kids are negative. And then if the cup is positive, then you subsequently retest those kids, right? So I think there are clever ways, as you said, to do this that maintains their ability to be in school and be educated and be with their friends. I read about one of the stupidest things I think I could have read about, which was a COVID party, like the old chickenpox parties before we had chickenpox vaccine, where, one kid would get chickenpox in the neighborhood and everybody would go visit that kid, so their kid would get chickenpox and then they'd be done with it, which was immediately asked by pediatricians not to do that as soon as the chickenpox vaccine came out, because it's much safer to be vaccinated than not. But now we have this happening where COVID parties are happening so everybody can get COVID, and then some of them are getting really sick. And then there's this article written by Craig Spencer talking about how well vaccines do protect us from spreading the disease to others. So maybe, Kristin, can you talk to us about that, about adult protection? Because I'm vaccinated, are you safer around me?
Yeah, that's such an important. I just want to give props to Craig Spencer, who wrote that piece, who's a wonderful ally for he, for she, and as you all know, is director of global health for emergency medicine at NYU Columbia. So before I comment on that, I also just want to go back to one more thing we were talking about before, if that's okay. So we were talking about how misinformation kills people and how it's been very challenging as healthcare providers and other professionals to see sometimes folks not participate in recommendations that are data-driven and that are recommended by people who are trying to save lives here. But I just have to say, I think it points to the importance of primary care. So I'm a primary care doctor, and I think there are a lot of folks out there who I see every week who are vaccine hesitant, and they're scared. They don't want the virus. You know, they don't want to be sick, but they just don't know what to do. They feel like they have conflicting information because of misinformation or different voices in their ears. And so when people are afraid, they do nothing, and they just haven't gotten vaccinated. But if they have a conversation with people who they have a relationship with and who they've known over time, like a primary care doctor, who they've had demonstrated caring for them, these conversations oftentimes can be very fruitful. And these conversations, thank goodness, have taken out also of the healthcare setting and are successfully being had in faith-based organizations by church leaders and pastors giving clear data to their congregation. You should be vaccinated. You're at risk. This is what can help you. So I think these conversations are best had in relationship by people who are trusted, and hopefully those relationships can be fostered in primary care. So go primary care. I just want to make a plug for primary care and the power of primary care in health prevention and health promotion. So getting back to Craig's article, I mean, I think it comes down to something that's very simple. You know, to spread the coronavirus, you have to have the coronavirus, and vaccinated people are less likely to have the coronavirus. You know, we know that people can get a breakthrough infection. Absolutely. Nothing is 100%. That's why we have that nice Swiss cheese model to be as protected as you can, but nothing's 100%. So that we know if you do get a breakthrough infection, you can get COVID and you can spread that to others, but the viral load is less. So if you've been vaccinated, your duration of shedding, your duration of sickness is less. So there's less opportunity, right, for you to give the vaccine, to give the virus to others. And then a lot of people who've been vaccinated don't get sick at all. And those folks are not going to be spreading the virus. So, you know, again, to spread the virus, you have to have the virus. Vaccinated people are less likely to get sick. And so vaccinated people are not as likely to spread. As what Craig talks about. So I would encourage people to read that article. It was in The Atlantic. And it's just puts all that nonsense to rest, I think, in a very clear way, as is Dr. Spencer's style.
You know, I think, first of all, props to primary care. My mom's a family physician.
Oh, lovely.
Yes. And a lot of ENT is actually, you know, lots of primary care and ENT. A lot of my patients will say, well, which one did you get?
Yes.
Right. And I said, well, I got Moderna because I happen to be a Dolly Parton fan. I actually got Moderna because that was the one that was there. And my parents got Pfizer. And so, you know, and my friend got J&J. And frankly, all three of us are well protected.
Yes.
Right. So, and I think it's really important to have those frank discussions. As I said, we are live on Facebook, YouTube, Twitter, and Shree's LinkedIn on Scroll.in. We'll be carried on WBAI.org from 2 to 3 p.m. on Monday, and we have a podcast. We have a great question from Craig Purdy that says, why are some parents more concerned with their kids wearing a mask than their kid getting sick? And we have a really interesting graphic, the blue bars graphic, that shows the difference between mask mandate communities and not mask mandate communities. So maybe, Natasha, do you mind taking this?
Well, I mean, I think that this is, as we kind of alluded to before, this is a political problem. This is a sociological problem. This is a psychological problem. This is not a science problem. And I think that people start to identify with their own tribes, and they start to believe these falsehoods that are then continued to be talked about through their tribe, and it perpetuates these myths. we know that masks work. We know that masks are keeping kids safe. We know that masks are limiting the spread of the illness within schools. And I have seen many kids who have been around positive classmates directly exposed, and they're both wearing masks, and the virus is not being spread throughout the class. We know that this works. I think there's also this that people are clinging to the wrong thing when it comes to kids and COVID. People are clinging to a very low death rate for a lot of their decision making. And I, as a person who cares for kids, I am so thankful. That the death rate for our children who get COVID is low. It is not zero, but it is low. But we're struggling with other things. Death is not the only outcome for kids, and kids have a lot of life years left, potentially harboring the ramifications of this illness for many, many years. We're seeing kids with long COVID symptoms. We don't know what to do with these kids. We're not sure how to best care for them. We are trying to learn from the adult models, but as we all know, children are not little adults. And so we're really trying to work together, both just in cooperation with other clinicians saying, what are you doing to help these kids? And that is another reason that we still don't want our kids to get this illness, even though they're not going to die. We still don't want them to get sick. And that's why we need this vaccine for little kids.
So we have this graphic up that's next to you looking at long COVID in kids, and they really do get all sorts of symptoms, and they get these long COVID symptoms with fatigue, with headache, with GI issues. As Kristin said, this is a virus that comes in through the respiratory tract but affects the entire body. And we are seeing very high rates in young children. And we are seeing long COVID symptoms in children who almost had no symptoms at all. So there's no correlation between severity of disease and the development of long COVID. And then if we look at the other slide that looks at long-term effects of COVID in adults, it's the same thing. We're seeing head-to-toe effects with headache, with tinnitus, with changes in smell or taste, with depression, with chest pain, heart inflammation, muscle pains, diarrhea, fatigue, recurrent fevers. We're seeing this in adults, again, not necessarily correlated to the intensity of their initial disease, right? So, Kristin, when you're taking care of elderly people, in the hospital or in the office, what goes through your mind when you're counseling about this?
So I think this topic really needs to be talked about more, because we do focus on this binary, like, am I going to live or die from the virus? And there is, an in between that is also very unpleasant, which is long COVID. It's recognized by the NIH. They call it post-acute sequela of COVID-19, and it's bad. So this is something that's causing significant disability, where people have symptoms, as you said, ranging from neurologic to mental health to more biomedical symptoms. And this is a people sort of, I think, are worried or nervous about the vaccine. I say, wow, let's be nervous and worried about this pathogen that can wreak havoc. We have a safe and effective vaccine. You don't want COVID, right? So in terms of long COVID, when I talk about, like you should with any intervention that you're recommending, whether it be a vaccine, a new medication, a procedure, a surgery, anything with your patients, that process involves a discussion that involves, informed consent. And so the process that you're trying to have in this encounter is trying to explain to patients, it'd be ideal if they could just see what was in your brain, right, about what you've seen. But you're trying to have a conversation with patients so they can understand the risks and benefits of the pathway. And the risks of not, getting the vaccine, of course, include getting COVID and dying, but also the risks of getting long COVID. And so I have started to incorporate that into my discussions of, it is absolutely your choice not to get vaccinated if you choose to do so. I want you to be able to make that decision with the right full information, and the full information includes knowing about the awfulness that is long COVID.
I just read an article early this morning about that looked at brain imaging, age matched and gender matched, and other issues like smoking, all the usual things that we match for, between COVID and not COVID. And there's actually loss of gray matter in your brain.
Yes.
In the frontal lobe and in the temporal lobe. So in the front part of your brain and in the side part of your brain with COVID. And again, not related to severity of disease, that's the thing that's flummoxing us, right? So we can say, well, you had really bad disease, so you're probably going to get really bad leftover. But, I ran into a housekeeper at the hospital who had 2 days of loss of sense of smell and was fatigued for 9 months later, right? So I think there are changes that are happening in the brain and in other organs from this illness. So please, please, please get vaccinated. Wash your hands. Use appropriately filtrated HEPA filter or open windows in classrooms. But then we're going to say get vaccinated. And Natasha, you've talked about the grown-ups being vaccinated. When are kids getting vaccinated? What's your crystal ball tell us? And I want to say Shakil Ahmed, who I think must be writing in from England or from the continent of Europe, says, good evening. Thank you for such a fruitful discussion of vaccinating kids and the myths regarding COVID-19. So thank you, Shakil, for watching and for chiming in. So Natasha,
we've got some glimmers of exciting news from Pfizer. They've released a press release that suggests that kids 5 to 11 are getting a safe and effective response to their vaccine. The Pfizer, we have not seen the actual Pfizer data, and certainly we don't make recommendations based on a press release alone, but I think it's reassuring to families that there is movement. There is movement in that process, because I know so many families are just so eager to get their kids vaccinated. There's some few more steps that have to happen, just like they had to happen for the adult vaccines. The FDA has to review all this data. They go case by case. They've got more weeks of data for the kids than they ever reviewed for the adults, so it may take a little while. It then goes to the CDC, the ACIP, and other governing bodies to help us decide how we are going to be delivering the vaccine and where it goes on the vaccine schedule, especially when you're talking about young kids and our other routine vaccines. We have to figure out, like, where is this going to go with our other routine vaccines as kids start to age over the next couple of years. So we do have quite a few hurdles. If I am telling my families by Thanksgiving, I think that I think it's going to take a little bit longer. I think it deserves to take a little bit longer. We have to take time to do this right. There is going to be an appropriate amount of vaccine hesitancy, especially for parents making this decision for someone else. And so we need to make sure that the FDA, the CDC, and the ACIP all have adequate time to review, to ask questions, to dialogue, to conflict, to talk about to really discuss very transparently the disagreements and let science tell us the answer. So we have been patient for this many weeks. I know people are eager, like I said, but I am very hopeful that by Thanksgiving we'll start to see a vaccine in kids' arms.
Well, that would be terrific. And I think what you talk about in terms of science and dialogue and discussion and disagreement is really important. There's a concept called the 10th man or the 10th person concept in a group where one person is just assigned to disagree. One person is just assigned to disagree, so that by disagreeing, they force the other 9 to come up with a much more rational, much more comprehensive approach to the plan. And I think that is the way we will keep our children and our communities safe. So, our viewers and our listeners hear that we are talking science, we are talking humanity, we are talking concern for the well-being of all aspects of the people that we treat and the communities that we treat. One concrete thing we do is we teach medical students how to do stuff. Like put a tube in somebody's nose that goes into their stomach, or put an intravenous line in. And back in the battle days, I must tell you that I learned that stuff on patients. I was shaking, the patient was shaking, everybody was shaking, but somehow I figured out how to do it. It's much more humane now with simulation. And Kristin, I know one of your many hats is that you actually help the medical students transition from their sort of book learning years to their clinical practice years. Can you tell us about simulation and what this picture is showing us?
Sure. One more thing just to sort of close out the topic of long COVID. The University of Michigan, my medical center where I work, actually has a long COVID clinic, as do a lot of other institutions across the country, like Beth Israel Deaconess has one that I saw recently. And that clinic is multidisciplinary, where there are cardiologists, pulmonologists, rehabilitationists, internists, general internists. And it's a response that the medical community has in trying to research, understand, prevent, and treat long COVID. You do not want to need this clinic. Okay, it's there if you need it, but you do not want to need it. So in that spirit, I encourage you all to get vaccinated. I just wanted to make a plug for the fact that, thank goodness, that the institutions have rallied around this with a multi-interprofessional approach to people who are suffering, really suffering with long COVID. So in regards to simulation, so yeah, I totally remember as a trainee also learning my procedures on patients, and you know, in the spirit of, thank goodness, of patient safety, we have really, over especially the past couple decades, embraced simulation in medical education. So simulation, right, as you so expertly explained, is a way for trainees and learners, and we're all learners, so attendings use simulation too, to learn how to do a new skill on a lower stakes person or mannequin. So for example, when our students are learning how to take a medical history, they learn how to do it from a simulated patient, like an actor. So when they're nervous or they don't really know what they're doing, or they're going to take a lot of time, it's a lower stakes because it's not really a true sick person. It's an actor. So they learn how to take a history from an actor. When we're doing procedures, we will learn how to do them on mannequins. So that picture that you just showed, for example, these are mannequins that we use in the sim lab, and our students will practice putting nasogastric tubes in. So this is a tube that goes into the nose, down to the stomach. We use it to do decompression of the stomach if someone has a bowel obstruction, or we can put liquids or medications down the tube. And, you know, it's a great way for them to practice. So they're not practicing on a real person. The other picture that was in that slide is we had practice doing IVs and IO lines and infusions. And, you know, we, thank goodness, have learned a lot from our colleagues and other professions who've used simulation actually for decades. So aviation space has used simulation for a long, long time. And we have aggressively adopted simulation in medical education. And the data is robust, right? That it shows that trainees can enhance their procedural skills, diagnostic skills. We use it for team-based simulation. We use it for like practice breaking bad news, taking medical histories. And hopefully the research will continue to show, and will show at some point, that it helps improve patient outcomes, which is the holy grail of data for anything that we do in medical education. But it's a great way, I think, to enhance patient safety and improve people's comfort and skills in different procedures before they have to do it on a real live person.
You know, we use it also in otolaryngology. Sonia Malexide, Ellen Deutsch, Kelly Malloy have been very much at the forefront of sort of low-cost surgical trainers. So you drain, let's say, a peritonsillar abscess, you know, in a cup, in a fake thing before you are in that sort of very scary situation with a patient in the emergency room. Anesthesia has been using simulation for a long time to train their residents of how to deal with sudden changes in the patient's condition on a mannequin, so that they don't panic and they kind of have a sort of a rote memory almost of what to do next. And I have to say, my daughter's Girl Scout troop had the greatest trip, because when your mother is a doctor, like the trip you envision is this trip to the sim lab. So they got to do some anesthesia sim at the Mount Sinai sim lab. Yeah, it was really fun, and they're so smart, these kids. It's unbelievable. Natasha, you actually, let's pivot a little bit for both of you, because I think both of you have been very much in the mind-body space. And I really appreciate it. So, Natasha, Dr. Burgert, you wrote a lovely article in Forbes looking at anxiety in children and what signs do we as parents or as teachers or as school nurses look for anxiety. And you talk very openly about parents being afraid to approach their pediatrician, that their child may be exhibiting signs of anxiety because they're afraid that they'll just get put on a pill, which is, I don't think the natural course of events. But maybe you can talk to us about different types of anxiety in children and what we should look for.
Well, that's a great point. And also, we could add this to the list of long COVID. We're seeing a lot of kids with mental health consequences after having COVID illness, but certainly just being in a pandemic alone and going through all of the trauma and grief that a lot of kids have dealt with. And we're also introducing a lot of kids back into the social sphere after a year and a half of really not going to school in any routine sense. And that itself is very anxiety provoking. A lot of kids also have developed very significant anxiety about illness. I mean, they have heard for the last year that there's something out there that's killing people. And if they are around someone that's not wearing a mask, or if they're around someone and they're getting too close, these kids are really getting upset because they feel like they're starting to feel personal threat. So I think that there is a lot of different types of anxiety, but it almost has really seemed to be accentuated because a lot of the normal coping mechanisms that kids have to help them with anxiety, so going to school routinely and being with their friends at lunch and having a lot of exercise at recess and going to their sports teams and having family events. These are ways that kids can do self-help, do work to help their mood and behavior. And those have really been taken away from them. So we're really seeing a lot of anxiety in kids. We also know that anxiety is very genetic, right? Like there's a genetic predisposition to have many different types of mental health issues. And so parents that have had a line of anxiety are certainly worsening anxiety since the pandemic starts. They are nervous. They are nervous to come in and bring their kids because they just assume that what we're going to say is, oh, of course they're anxious. They're anxious just like you, and you're on medication, so that's what we're going to do to your kid too. And so I think that keeps a lot of parents from being forthcoming of how significant the symptoms are with their kids. But I want families to be assured that we are partners for the whole health of children, and medication is not the first line treatment for anxiety in children of any age. We want them to be able to utilize a variety of different coping mechanisms that need to be taught through our therapists and our school counselors and our trusted teachers and other adults in our community that can help these kids. That is what we want to be able to connect our kids with. It's only when kids are not responding to those type of interventions, or it's getting so severe that we're worried about suicide or other significant safety issues, that we start to talk about medical therapy. I will say that medical therapy is very safe. It's very effective. It's tested on kids. I feel very comfortable, and most general pediatricians feel very comfortable prescribing anti-anxiety medicines when we need to get there. So we want to partner with families for the whole child. That includes physical health and mental health. And it is going to be very much shared decision-making on how severe the symptoms are that a kid has and what that kid needs in the time of the developmental age and school and every other resource that we have. We're going to work together. But I just want to encourage families to really reach out if they think their kids are struggling.
So thank you. I think that's a really important message. I think, Robin Cogan said she's going to read this article. I think, thank heavens we're back in school, because I think as parents, we realize how much the teachers and the school nurses really do help our children, not only their routine, but we have other caring adults who are looking at our kids and can call us and say, hey, little Jimmy's, had some issues with this. Let's talk about it. And I think that's really crucial. We are live, as I said, on YouTube, Facebook, Twitter, and on Shree's LinkedIn page. We're on Scroll.in. We'll be on WBAI 2 to 3 p.m. on Monday Eastern Time. And we have a podcast. So please like and share and tag and let your friends know. They can always watch us offline, but we love the interaction online. So thank you for sending your messages and your questions. You talked about mind and body, and let's add the third leg to that stool. Let's add spirit. So I found that many times in medical education, that religion and spirituality of the patient or the caregiver was almost treated like that third rail on a train track that you don't touch because that's the one you're going to get electrocuted by. So somehow we just don't talk about religion and spirituality, but 80% of people across the world describe themselves as religious. And certainly, I'm sure you have had it. I've had people come in and say, doc, is it okay? I went to church yesterday and I lit a candle for you so that my family member's surgery would go well tomorrow. And I happen to be Hindu. And, they're a little nervous telling me that. I'm like, oh, I will take every prayer, every good wish I can get. And I find that my practice is much more gratifying to me when I can engage my patients in discussions of their spirituality or their beliefs. So Kristin, you put your money where your mouth is and you started a program. So can you talk to us about that program at Michigan?
Sure, I would love to. So at the University of Michigan Medical School, we have a program on health, spirituality, and religion. I'm the founding director of that program, and I run the program along with Lori Kwaipavalu, who's my administrative assistant, and 3 other wonderful faculty members. And we have been running the program since 2017. So I agree with you, right? That when we think about whole health, we think about mental health, right? We think about physical health. But as Cicely Saunders, who is considered to be the mother of modern day palliative medicine, said, we also want to consider health in 2 other domains that are often left out of the conversation. Social health, which, my goodness, social health has been completely threatened with the pandemic. People are socially isolated, and that has significant impacts on mental health and physical health, right? And the last domain is spiritual health. And I can't think of a time in my adult life where people's spiritual health has been more threatened as it is now during the pandemic, because the pandemic inherently, with its nature of threatens us with death and disability, brings up questions of meaning. And so spirituality, if that topic freaks people out, spirituality basically just at its very root, and its a very broad definition, is anchored in meaning making. And people's meaning is threatened when they face serious illness. And I take care of adults with chronic medical problems. And I always have patients who are in various stages of serious illness. And they have spiritual concerns. And if we want to have a healthcare system and a method of care that approaches them in the fullness of their humanity and really has attention to whole health, we need to be able to engage them at these levels of their deepest commitments and their deepest concerns. And thank goodness at places like Michigan Medicine, and I know a lot of other institutions as well, we have care partners that will help our patients through these difficult challenges. Our chaplains, we have a spiritual care department. People oftentimes will have their community rabbi or their priest can come and see them at the bedside. But if we don't even know that these issues are there with our patients, how can we get them the care that they need and that they deserve? So I've been really, really happy to be able to run this program. And we're really the only program like it in the country. We're at a secular medical school. We have this program, but it's dedicated to whole person health.
So Craig Purdy is saying, I appreciate and respect a doctor who's not afraid to include God in a conversation about my health. And yes, as do I, and as do most of our patients. Shamala Devi says, I'm glad you said medication is not the answer for treating children. Well, it's not the only answer. And I think that's the important thing. There's so much that goes to evaluating people. Kristin, I want to stay with your program for a second, because you talk about spirituality as we deal with patients, but how about, there was a really terrific letter to the editor you wrote with one of your colleagues that talked about going from a culture of blame to a culture of grace. And I think for us to almost heal the healer so that we can be in the right place when we take care of patients. Can you talk to us about that?
Sure, briefly, because I know we're running up at the hour. Totally. This topic is a beautiful topic, in my opinion, because it intersects with patient health and with the health of healthcare providers as well. We are in a crisis of burnout in this country with medical health practitioners, especially during COVID, right? People experiencing significant amounts of burnout. And the data shows that about a third of physicians went into medicine because of their spiritual and religious commitments. But then when they get to medical school or they get to training, we make it seem like for them to be a professional person of science, they have to basically leave their religious commitments at the door and sort of hide that or have that be a marginalized or hidden part of their identity. But we know that identity actually helps anchor their practice in meaning, and meaning making in your vocation is a tool in which to prevent burnout. So this is a piece that I wrote recently with a PhD student at Michigan Medicine, Kyle Ganji. So I just want to say did a lot of the heavy lifting on this piece and a lot of the writing and editing. But we talk about transitioning in medicine from a culture of blame to a culture of grace. We talk about this piece and specifically around patient safety and how hard we are on ourselves when things don't go the way that they're going to go. And in medicine, it's an art, not a science. And we have a very, very, especially Michigan medicine, a high acuity, and things sometimes go wrong despite our best efforts. So how can we forgive ourselves? How can we show ourselves some self-forgiveness? How, as a community, can we provide some grace to those who are putting themselves on the front line? Because people like Tyler Vanderweel at Harvard School of Public Health have shown that forgiveness actually should be considered a public health effort, because when we forgive and when there's grace and mercy in a culture, the toxicity that's often there that we see can be mitigated, and that's what we talk about in that piece. Thanks for bringing that up.
You know, there was an opinion piece. They used to be called op-eds, but now they're called opinion pieces in the New York Times by an Episcopalian minister, Tish Harrison Warren,
Yes.
talking about COVID fatigue. So now we're not talking about the fatigue of COVID illness or of long COVID, but of being just sick and tired of COVID. And I wonder, Natasha, if you can talk to us about, you know, we've been saying COVID for like, I don't know, 18, 20 months at this point. How do we get rid of our COVID fatigue as healthcare providers and help our communities not get so tired of this that they stop caring?
Right, that's a difficult question, both personally, because I know that any healthcare provider is waking up on different sides of the bed depending on their level of compassion, and that's part of that fatigue factor too. But I think that we can remember that this is going to be over. It's going to be over. It's going to be a chapter in the history book, and so we need to remember that we still need to care for one another. We need to look at our kids in the face. We need to be able to give eye contact to people that we love. We still need to get good sleep. We still need to get good nutrition. We need to be caring for each other, even though we have this stress and this overwhelm sense of dread at times with all of this fatigue that we're dealing with. We are in a community. We are working together. We need to be kind to one another, and we will get to the end.
And Kristin, what's your take?
So Tish Warren is an Anglican priest, and her pieces are weekly New York Times. And she talks about in the piece, right, how as Christian people, we have hope because we know how the story ends according to the scriptures, that God will make all things new and Jesus will wipe away every tear and everything will be restored because we are in a broken state of affairs and this isn't the way things were supposed to be. So as Christians, we have this eschatological hope of things to come that can help us sort of fight the fight and run the race. But she says in the meantime, we are to do the things that Natasha said. We are to grieve, we are to mourn, we are to lament, but we are to have hope in the things to come. And she said that type of hope, as the book of James says, will give us perseverance, and perseverance will complete us or make us whole in that process.
You know, I think the concepts of patience and perseverance and breathing and frankly taking the opportunity to meet amazing people such as the two of you and get re-energized from time to time is really very, very important. On behalf of Marina and myself, I want to thank both of you for being with us today. We've had the pleasure of speaking with Dr. Kristin Collier, who is Assistant Professor of Medicine at the University of Michigan Medical Center and the founder and director of the Health, Spirituality, and Wellness health, spirituality, and religion program at the Department of Medicine there. We've also spoken with Dr. Natasha Burgert, who is a pediatrician in Kansas, near Kansas City, who is also a writer and a spokesperson for the American Academy of Pediatrics. These are both incredible women and a wonderful way to wrap up Women in Medicine Month. So thank you both for being here. Thank you so much to our wonderful team who puts everything together and lets things run smoothly. We certainly couldn't do it without this army behind us. Our producers, Rose Horowitz, Vandana Menon, and Julia Weeks. Video highlights by Keval Ramanathan. Our design by Shristi Hebar, and the lovely voiceover in the beginning by Nicole Lewis. Thank you to WBAI for carrying us on Mondays from 2 to 3 p.m. And thank you all for kind of tuning into our podcast on Apple Podcasts and on Spotify. Let us know what you think. We are doing shows every second and fourth Sunday this season. So we will see you in 2 weeks. Be safe, get vaccinated, wear a mask, be kind.